Right. So it's my huge pleasure as the first speaker for a proper talk tonight to introduce Dr. Reinhard Max Wolff, a very dear colleague and friend. We've been working together for several years now, both clinically and in teaching. Max is a clinical psychologist, psychotherapist, and psychotherapy researcher. And he is the head of the APT program at the Mind Foundation and also heading our research in psychedelic topics to do with psychotherapy. And Max today is going to speak about psychedelic therapy is psychotherapy, connecting the dots between two fields that belong together. And I think it's a very important talk because this is a discussion we have to have. Is two separate entities? Are we actually at a point where we try to reintegrate something that has been pulled apart because people haven't given enough attention to the psychotherapy that is actually in this or has been in this for a long time or perhaps forever? Thank you.
Thank you, Andrea. Something changed about this presentation. But yeah, I suppose that's how it is with psychedelics. You have to be open to whatever comes. Yeah. Let's see if this works. Welcome to Berlin. Why is psychedelic therapy psychotherapy? This is actually just a proposal. Yeah, I don't present this as fact. Yeah, but this proposal is based on two assumptions. The first assumption is psychedelic therapy outcomes are, at least to a substantial degree, mediated by therapeutic experiences. And the second assumption is that these experiences drive the same psychological change mechanisms that underlie the efficacy of all effective psychotherapies. I will not present the conclusive evidence for this today. That's for future publications. I will just illustrate the idea. This here is perhaps the most replicated non-trivial finding of psychedelic research. The psychedelic experience mediates longer-term outcomes. Here are 3 examples from clinical studies testing psilocybin for nicotine addiction, for depression, and for anxiety associated with cancer. And all of these three studies found that the so-called mystical type experience predicts longer-term outcomes, therapy outcomes. So the mystical experience is important, but it's also not the only important aspect of psychedelic experiences. There are many other aspects of psychedelic experiences that also predict longer-term outcomes. This is just a selection of examples from clinical studies, but also from experimental studies with healthy volunteers, and also from naturalistic studies, survey studies with naturalistic psychedelic users. And there are mystical type experiences, but also things like emotional breakthrough experiences, acceptance, avoidance-related experiences, different kinds of insights, and so on. So there are many aspects of psychedelic experiences that are of therapeutic importance. But also, it's important that not all aspects of the psychedelic experience are therapeutically relevant. This is an important study from Switzerland this year. Our colleagues tested psilocybin for depression, and they found that psilocybin was effective. And they also looked at different aspects of the psychedelic experience and calculated correlations with the therapy outcomes. And they looked at very broad, different measures, changed meaning of percepts, audiovisual synesthesia, disembodiment, experience of unity, blissful state, anxiety. It's very broad. And actually they found that most of these aspects of the psychedelic experience are not strongly related to the therapeutic outcome. Some were more strongly related, and the most strongly related aspect was actually insightfulness. And I don't think it's a coincidence that insightfulness is also the one that's most obviously related to psychotherapeutic processes. Yeah. So what do we take from this? Oh. So first of all, the overall intensity of psychedelic experiences is probably not so relevant therapeutically. Second, we must pay attention to those aspects of the experience that are of psychotherapeutic relevance. And for that, we must understand or have a broad understanding of how psychotherapy works. So how does psychotherapy work? Well, you may ask, what psychotherapy? There are many psychotherapies. They must all work differently, don't they? And, well, according to psychotherapy research, the answer is yes and no. So these different therapies, they use very different methods. But these methods serve to drive the same underlying change mechanisms or common factors. In the history of psychotherapy research, various models of so-called common factors have been proposed. They're all compatible. They're not competing models. They actually complement each other. And today I just want to present one model that works really well with psychedelic therapy, and that's why we also put it at the theoretical basis of the APT training program in mind. And that's the model of general change mechanisms that was proposed by Klaus Grawe, psychotherapy researcher from Germany who worked in Switzerland. And Grawe, he proposed that all effective psychotherapies, to some degree or other degree, work based on these 5 general change mechanisms. I will just walk you through each one of them. So the first one that I want to present is problem actuation. In very simple language, this refers to the process of engaging with feelings that one would otherwise avoid. So all effective psychotherapies have to do that. There are some overlapping constructs with this in psychedelic research, challenging psychedelic experiences, avoidance-related experiences, also things like re-experiencing adverse life events in a psychedelic state. And I want to illustrate, just to illustrate how this change mechanism also occurs in psychedelic therapy with a quote from a patient from the episode trial. So people are interviewed. This is from a qualitative interview in the episode trial. It's just been a very, very intense way of dealing with my emotions without being able to build a protective wall. I think psychotherapy or psychoanalysis serves to strip away the protective walls layer by layer by layer to get to the core. And that just went a lot faster with psilocybin. I got to the core much more quickly, and as a result, I was also much more unprotected. So I chose this quote. I like it a lot because it's ambivalent. Yeah. It shows a great potential of psychedelics for problem actuation. It also points to some obvious risks. Do we want patients who are completely unprotected? If so, under what circumstances do we want that to happen? Yeah. And who should be allowed to get a patient into such a state? Yeah. So important questions. If we look at psychotherapy research, there's one important answer. What's a good context for such an extreme experience of problem actuation? That would be a functioning therapeutic relationship and resource activation. Resource activation, the second change mechanism. This refers to the process of developing positive motives that serve the fulfillment of basic psychological needs. Things like orientation, control, attachment, pleasure, self-esteem. These are positive experiences that also happen in all effective psychotherapies. Overlapping constructs in psychedelic research, again, the mystical type experience, surely a resource-activating experience from a psychotherapeutic point of view. Experiences of connectedness, also certain kinds of insights about goals and positive patterns, adaptive patterns. Here's another episode patient. I saw my true self, the person that I really am. that I'm actually an active person. I like to move. I like to be loud sometimes. Not always just this holding back and being quiet. I actually like to do things and be with other people. I always thought I was just a person who prefers to be alone. And that's not necessarily the case. I'm also not as cold and heartless as people might think. I'm more of a warm person deep down. I'm actually a person who likes to make shenanigans or play around. I've just always suppressed that. Now I'm trying to learn to allow it. So resource activation together with problem actuation will often lead to certain therapeutic or corrective experiences. There are two types. In this model, there are two types of corrective experience. The first type is mastery experiences. This refers to the process of learning new abilities for dealing with difficult feelings in challenging situations that were previously too difficult or challenging to be confronted. Yeah? There's also another overlapping construct here, emotional breakthrough experiences, acceptance-related experiences. These are just overlaps. They're not perfect, perfectly corresponding with one another. Another episode patient with a mastery experience. Then I was able to apply what I had learned before. I'm feeling this now. Why am I feeling this? I don't know. But I just look at it and let it flow through me, and then we just see what happens. And that was always right in every way. I mean, even then I still experienced some dark minutes, but I no longer felt helpless about that. That was hard for me in my depression, that I could not do anything against the darkness, the negativity, because I always thought that I had to do something to counter it. And that turned out to be an illusion. I didn't have to fight at all, or have that one clever thought, or cut the Gordian knot, or have someone else come save me. All I had to do was look at it. Such things can also be read on Facebook and in calendar books, but when you've really experienced it, that's something else. Experiencing is just a different quality. So this is a psychedelic mastery experience. Yeah. The second type of corrective experience, clarification experiences, gaining awareness of unconscious emotional patterns and learning to recognize, understand, and question them. If you're a psychoanalyst, you may nod now. That's what psychotherapy is. Yeah. Overlapping constructs in psychedelic research, again, insights about avoidance and maladaptive patterns, emotional breakthrough experiences. They overlap with both mastery and clarification. Yeah. In retrospect, I think my depression was due to my deep self-loathing, self-hatred, lacking or non-existent self-esteem, lacking or definitely non-existent self-love, and then just self-hatred as an extreme manifestation. I think that almost all of my symptoms can be traced back to that. When I couldn't love myself, when I couldn't respect myself, when I couldn't appreciate myself, I didn't have the idea that other people could appreciate me. And I think that was one of the reasons for my fear of other people. Ever since I started to feel that I'm valuable myself, that I'm valuable to myself, I accept much more easily that I could be valuable to other people as well. And I think that's the whole crux of it, as far as social things are concerned. A psychedelic clarification experience. Now, perhaps the most important of the change mechanisms, the therapeutic relationship. Working together on the basis of mutually agreed therapeutic goals and a positive emotional bond. On the right side here, this is, I think, one of the most important studies in psychedelic research in the last years, because it's actually, I think it's the first study that took a concept from psychotherapy research and tested it in psychedelic therapy. Psychedelic research and psychotherapy research hardly interact, although they are so clearly relevant with one another. Yeah? So they did this, they measured the therapeutic alliance on the day that was established in preparatory sessions. They measured this on the day before the dosing session. Then they found that this predicted therapeutic rapport. That's something like more like the emotional bond on the day of the dosing session. And that in turn predicted emotional breakthrough experiences in the dosing session. And that finally predicted reductions in depression severity. Very important finding. I want to illustrate this with another quote from the episode study. I will never forget the two hands, Mrs. X on the right and Mr. Y on the left. I will never forget how their hands felt. I asked them to help me through this now, and they did not leave me alone. And I asked them not to let me off the hook either, I wanted to get through this. I wanted to somehow find the way out of these negative images and this shame and these self-destructive thoughts. I asked them not to let me escape, and they didn't let me. Mr. Y was strict with me, but he was very, very good. And Mrs. X was very loving and kind to me, and she gave me the feeling that what is happening right now is good. This is not trip sitting, and this is also not psychological support. Yeah? This is a therapeutic relationship. This is working together on shared intentions. Yeah? This is not trivial stuff, and this is also work with professionals who know boundaries, have to know boundaries. This brings me to the important point that these therapeutic experiences, they do not fall from the sky. They depend on a context, an immediate context that has to be taken care of. And that in turn depends on a superordinate context. Such a superordinate context ideally would contain a functioning therapeutic relationship, an effective therapeutic process. And these photos, they're from the APT program, where we learn this together, shaping this beneficial context for therapeutic experiences and for effective integration. So what do we do at Mind to connect the dots between psychedelic research and psychotherapy research? The first thing is practical implementation, the APT program. Theoretical integration, papers and books we have written and are writing, and we will be writing in the future. Qualitative research. In the episode study, the quotes I read to you, they're from our qualitative study. This will be the largest qualitative study that has ever been conducted in psychedelic therapy research. We will interview about 100 patients, and the focus of this will be, one of the focuses of this will be on general change mechanisms. And not least quantitative research. I just want to point out two questionnaires we developed, the APEC, to measure avoidance and acceptance in psychedelic states, and the general change mechanisms questionnaire. This is a new questionnaire to measure the 5 general change mechanisms that I presented here today in the context of psychedelic experiences. And with this, we hope to allow more exchange between psychotherapy research and psychedelic research. Yeah. So psychedelic therapy is psychotherapy. I hope I could illustrate that idea a bit today. Psychedelic therapy is also, of course, a pharmacological therapy. These are just 3 examples of neurobiological mechanisms of psychedelics that will be discussed here at this conference. And I just want to clarify that these are really not competing models. They're complementary models. They're 2 sides of the same coin. Yeah. And they can be combined into a biopsychosocial model. Sergio, we had the same idea here, I think. You can judge who did it better. Yeah. So I want to end with a typology of objections against the effort of building such a biopsychosocial model. The first one is always welcome, of course. Constructive skepticism, show me the evidence. Yeah. I hope to see a lot of that here at the conference. But there are also other more simplistic objections. Biological reductionism. Psychosocial aspects can be ignored. Yeah. Or less known but equally simplistic, psychosocial reductionism. Biological aspects can be ignored. In the field, in the profession of psychotherapy, there is traditionalism. Drugs of abuse cannot possibly play a meaningful role in psychotherapy. Yeah. There's also tribalism in the psychotherapy profession. Only my own preferred brand of psychotherapy provides a valid approach to psychedelic therapy, not the others. And then in the psychedelic field, we have psychedelic exceptionalism. Matt Johnson has written about that. The psychedelic experience is so special, too special or sacred to be accommodated by profane theories. And then not least, magic bulletism. Why bother building theories at all? Psychedelics are so inherently good, they will solve all of our problems anyway. Yeah. These simplistic views actually exist in our field. The reality of psychedelic therapy and of psychedelics more generally is complex. A conference like this with diverse topics, I think, is an ideal opportunity to embrace that complexity and connect the dots together. Enjoy the conference. Thank you.
So even though we're a little over time already for this part, we would like to take 2 questions. And the way we would like to do it, you've got a piece of paper in front of you. If you want to have a question, please write it down and give the paper out to your right, and will be collected in the staircase on your right. So if you've got a question, please write it down and hand it to your right. And there might be online questions too. Leander? Not yet, okay. So is there a question somewhere being written down? I don't think this, we have to recheck if this model works. I'm not sure about that, but we'll make progress over the next few days. Others?
It's an interesting kind of data collection.
Quick writers are definitely in the front line. So there's a question coming now. Do you want to read it? Or?
Do you think that it is important that a therapist has had experienced a psychedelic journey themselves? That's a whole conference. Yeah. Well, I want to do this one very briefly. I think it helps. I think we should rather not think about the whether or not someone has had experiences or how many, but rather how. What kind and in what way. Yeah. And also, while we're already at it, we should also think about the reality that a lot of people who are drawn to psychedelic therapy probably overdo it a bit. Yeah. So there can also be too much, and there can be unhealthy ways of using psychedelics, and that also I think is a really relevant question for training psychedelic therapists. Yeah.
Does the therapeutic relationship in psychedelic-assisted therapy need additional regulations and boundaries to the highly vulnerable state? Or are traditional ethical guidelines enough?
Yeah, good question. I don't have a definite answer on that. I think trained psychotherapists will probably not be surprised when they read through our therapy manual that we have for the study and read the suggestions regarding touch, for instance. These things they're not outlandish or strange from a normal psychotherapeutic perspective. But I think a lot of psychotherapists, for instance, they're probably not familiar with the situation of holding a patient's hand. So these things need to be discussed and trained also. Yeah. Yeah. So much from me. Yeah.
Thank you, Max.